it is an honor to be meeting you today. Those of you who don't know us, I feel like I've known you for 25 years. I mean, gosh darn, you've got 6,000 posts on Dentaltown. I'm your biggest fan. You seem to talk the most about endo of everything you post on. I would say, is it fair to say 80% of your posts are probably root canal related?
Yes, yes.
Yeah, and
That's,
man,
that's my major interest.
I just love you like a brother. I'm a big fan of your posts, big fan of your cases. You're always keeping it real on Dentaltown. Thank you so much for joining me today for an hour, Guy.
You're welcome. I am honored.
So
It is.
it's Guy Moorman, and you're in Georgia,
Yes, Douglas, Georgia,
Douglas.
small South Georgia town, and that's what was so great about Dentaltown and some of the others because when you're in these little small towns, you can get very professionally lonely, and as you know, I mean, you don't have anybody to talk to, and the internet brought Dentaltown, and the first one was Internet Dental Forum, which I'm not a member of anymore, and but now I spend most of my time on Dentaltown. There was another one, but it's turned into a political nightmare, so I just go to dentistry. I want to talk about dentistry, not politics.
You mean like the politics of the country, like political
Yeah,
part? Oh, yeah,
yeah, yeah.
yeah.
Political politics, not the dental politics.
We like to on Dentaltown. If dentists want to talk about that, that's fine. Under leisure, there's a political section. We just don't let the section on politics or religion or sex or anything like that show up on the today's active topics. So when you go to Dentaltown, you look at today's active topics. It's just pretty much clinical dentistry. But if you are a diehard into politics and all that stuff, I do believe that dentists, if they want to talk about it, they can. So if you go to the leisure section, there's a forum there. But at 52, I don't like to talk about religion or politics because I'm thoroughly convinced you're never going to change anyone's mind anyway.
Uh, exactly right. And I'm 71 and been in this business for 50 years. So, um, uh,
Guy, the reason I wanted so desperately to interview you is because, there's so many townies who have read your 6,000 posts over the last, decade, and so I want to start this off. You just said you've been doing this for 50 years. When I'm in dental schools, I'm in a half dozen dental schools a year, and the things the kids tell me, the first thing they tell me about what you're most passionate about, which is endodontics, is it's so overwhelming. So I want to start this conversation, Guy. Pretend, what would you tell a 23-year-old kid that just walked out of school and has a root canal scheduled tomorrow and is probably not going to sleep very well tonight and it's just so overwhelming? I only got you for an hour. What would be the low-hanging fruit you would tell these people getting into molar endo?
getting into motor endo, I would. Dentaltown's a good place to start. There's some good people on there. We have 4 or 5 endodontists that are on there now. We had a lot more at one time, and but we've lost some of them because of an incident that you're very well aware of. That, but we don't need to discuss that. But
No, go ahead. What was that instant, or what was that?
well, it was Barry Musicant, who was an excellent endodontist, but all Barry wanted to talk about was safe-siders, and every conversation that came up, Barry just inserted safe-siders into it. It didn't matter what it was, and after a while, he threatened to sue another endodontist that was on there, and that's not acceptable on Dentaltown. And
Yeah, under the terms and conditions that you agree. A lot of people. Let's just refresh a couple things. A lot of people, they tell me that that they have free speech and they're upset when they're banned or something. And the bottom line is, you have free. The Constitution is free speech between you and the government, but you're not
yeah,
allowed to walk in my front room at my house and start free speeching. I have the right to shoot you. So
yeah,
on Dentaltown, how we play that is it's a party at my house. I mean, I own it. It's not the government. I have no partners, and anybody can discuss anything till the cows come home, as long as it's like a party where you're having fun debating. But once it
yeah.
gets mean and nasty and personal, that's not a fun party. And I think dentists are so beat up by insurance companies and patients and staff that Dentaltown should be a fun, safe harbor to go and share ideas. But I do want to say one thing about Barry, since you did mention him, is I love Barry Musican, and what's so neat about Barry is if any of you dentists ever go to Manhattan and walk in his office, he's got like 6 endodontists. They're open 7 days a week, and my God, I can name you 20 people that just walk in there, and Barry literally sat down with them for like 2 hours showing them stuff. But you're right. If your only tool's a hammer, everything looks like a nail, and he just doesn't. He just wants to use his safe cider file, which is a great file and all that. But you're right. No matter
Yeah,
what question you ask on Dentaltown, he would start to solve it with a safe cider.
I actually used safe cider technique for a couple of years, and then I took a course, and I found out that maybe it required me to remove too much dentin in the very in the cervical area of the tooth, which is critical, and that's a big issue now. And it's uh, there's a battle over access. I don't know if you've noticed that. There's a minimalist movement where they want to get it smaller and smaller and smaller. And I just took two courses. One was Dr. Martin Trope, and the other one was Cliff Ruddle. And both of these guys are excellent endodontists. And I think their advice to young dentists who were what mostly was there was you can't work through a pinhole. You need to be able to see. Now, as you get better and better and better, you'll notice your access is getting smaller and smaller and smaller. But don't try to do, and that would be a young guy. If he started, that'd be the first thing I would tell him. Get where you can see all the canals, and just don't open up the orifices too big. That's where the vital part of the tooth is. And we had a discussion right the other day. I mean, you're lucky you got some good administrators on there that will, if it starts to get a little bit nasty, they'll calm it down or they'll take the post off, which is great. Because I've had some of mine removed, and it's sometimes you get a little too involved in something, and your administrators. Peter's one of them. I don't know who the other
Peter
one.
Wacko? Peter Wacko?
Yeah, that's right, Peter Wacko. He's a great one, and Howard Goldstein used to be on there. Now he's in charge of education, I think, on Dentaltown, and he was a great one. But that was the two that I knew the most. But it's
Can I add one thing on on that? What the comment you said is for me it was a when you're doing molar endo, you look at these people and they're writing down 3 or 4 different file links. It'd be like 19, another one would be 21, another would be 18, another one would be 23. And
yeah,
for me, all that cuss. What I like to do is I like to prepare the final restoration first, because then you got when you reduce the tooth to 2 millimeter, the occlusal clearance, that makes it easier to see straight down into the canal. A lot of times when you're removing all the decay and all that stuff, the top's parallel. Seems like my working links when I prepare the tooth for the final restoration first, if I have 4 canals, they might be all 418. And it's
yeah,
kind of a neat thing because if 3 of them are 18 and one of them is 19, I'm pretty suspect that 19 is long. And when I prepare the tooth first and get it all ready for the final restoration, then I can make my access. I know I can make my access prep bigger because I like the visibility too.
yeah. And I do the same thing. I never work. On. I don't even do a palliative treatment on one if there's decay in it. Uh, and that's a big complaint I have. A lot of people send these cases. I've seen them to endodontists. And they look at them and say, okay, this needs endo, and it's a mess. And what they should do is prepare their final restoration, like you said, and they don't necessarily have to prep the tooth, but at least do the build-up, and then go to there and do your palliative. So when you send it to the endodontist, he doesn't have a mess of decay and stuff he has to get out before he goes. And a lot of times when he takes it out, he'll find out the tooth's non-restorable. And we should do that in the office. That's not the responsibility of the endodontist. And that's a big complaint I have. But And I think endodontists do too. But it's not going to change, Howard. I don't know. I think we are getting lazier. It seems. I went to a Pentron meeting in Boston one time, and there were three of us that were general practitioners, and then there were like 15 that were teachers and researchers and people like that. Leinfelter and some of the others were there, and ironically, they were developing a bonding agent like a Generation 7, and they polled the room, and all of us but one were still using Generation 4 because it has the strongest bond strength. But one of the general practitioners there said he wanted the 7. He was the one that was using it because it was easier. And he didn't understand they were introducing RTs at that time, which is now sort of slowly falling out of favor. It's a great material, and I still use it. But he said, we don't need but 3 shades. Well, I couldn't disagree with him more, and I told him that. But we're just getting lazier. We don't want to have to think. We want somebody to do it for us. And when I started, there was not a whole lot to learn in dental school. I mean, you learn to give anesthesia, and you learn to do crown preps, and you learn to do amalgams, and composite was not. When I was in dental school, we didn't have composite. It didn't exist. The first time I saw composite was when I went into the military in 1969. There on the shelf was adaptic, and toothpaste, and you filled it. It was just, and that was amazing since we'd been using a glass ionomer or a silicate cement or something like that, and you had to fill it and wait a day for it to set up and get them back and polish it. But things have gotten now to the point where these young guys have so much to learn, guys and gals. We have a lot of women in dentistry now, and I think that's good. I wish all of them would stay in it. A lot of them don't, but there's so much to learn that you can't learn it in dental school. It's impossible, and that's the reason I think that we should have, rather than having a state board to get your license, I think we should require a residency of at least a year somewhere. Of course, that would take a major change in the way we do things. Hospitals would have to open up residencies. Of course, I went in the military, and we rotated through surgery. Actually, we had endodontics, we had prosthodontics, sadly pedodontics, which I did not like, but we rotated through all of that 2 weeks at a time. So I had a rotating residency, and it prepared me for when I got out and got home. I was ready for just about anything that I was going to see at that time. But now things have gotten, I mean, we've got implants, and we've got so much now that's it's so much fun. You can do stuff that I could not even imagine when I got out of dental school. It's just, I saw the old blade implants come and go, and I have a patient that actually still has 3 blade implants in it. They're loose, but things now, implants are so predictable. Endodontics are predictable. Of course, we're getting a lot of, with the new cone beam stuff, we hear a lot of, well, if you look at all these root canals, they're failing. A lot of that comes from, I don't know if you remember, there was back in even the 50s, there was a foci infection sort of theory. If you had arthritis and you pulled your teeth, if you had a bad back, a arthritic back, you pulled your teeth, and supposedly you got well. But sadly, a lot of people pulled their teeth and didn't get well. So that was not the reason. When I started, lots of people had their teeth extracted to get rid of a bad knee, and it turned out, well, it wasn't their teeth, it was something else. But now we're finding out that the oral cavity does have an effect on a lot of other things in our body, our heart, liver, kidneys, joints, but not the way that we thought back in the 60s when I was in school. But and it was I'm not real sure, Howard, that endodontist. I don't think we had an endodontist at Emory when I was there. I'm thinking, I don't think we did. I know there was no program there. There was no residency in endodontics because the way they started it, they had to grandfather in a lot of guys that had been doing endodontics just to get the specialty started. So a lot of the endodontists back then were grandfathered in type things.
And you still see that today. I'm not a lawyer and I don't want to pretend to be one, but and state boards are different in all 50 states. So if you're listening from around the world, the United States, the laws are confusing because some things fall under one law from the federal government for the whole country, and half the laws are state. But a specialist, when there's 9 specialties according to the ADA in the United States, so the specialty of endodontics, a lot of people have to go to school now to be an endodontist specialist, but you can have a practice limited to endodontics where you're not a specialty. Because when I go into small towns, I've met a dozen dentists where they were in a small town of 3 or 4 or 5,000. There were 4 dentists. The other 3 guys hated doing root canals. And one dentist said, you know what, I'll only do endo. So I'll send back the crowns, the fillings, the cleanings, the hygiene. I'll just have a practice limited to endodontics. And they're just crushing it. And they never went to endo school. So rural America has this. But I'm going to start pinning you down on some specifics because you've been doing this for 50 years. And when you and I got out of school, the data is still showing on a buildup, on a root canal buildup, that a silver filling on average lasts 14 years and a composite on average lasts 7 years when we're talking about like an MOD or 2 or 3 service. So, Guy, I want to stop you right there. What's the better buildup? If it was for you or one of your 3 children, would you rather put a couple double spills of amalgam in there, or would you rather do a composite? Talk them through the pros and cons of those 2.
You're going to ask me which would I prefer as a buildup. As long as it's not packed down into the canals, I would prefer amalgam because number one, it's easier to see your margins when you cut the crown prep. I mean, you don't have to worry. What I do is I use a purple flowable that Ultradent makes. And when I do my build-up, around all the margins, I put that purple flowable. So when I come back to prep it, I don't cut my margins on composite. Most of what I do now is most of my build-ups are composite. And that is because of demand. Patients don't like the black stuff anymore. And then we hear the stuff about the mercury. And but let me tell you, Howard, if mercury killed you, I'd have been dead a long time ago because I have breathed it, I have handled it, I have done everything you can think of with the stuff. And some people would argue that I'm crazy, but I'm not dead. So it's.
I would argue that all 7 billion people on Earth are crazy. I don't think any. And if anybody tells me they're the normal one, they're batshit crazy. Okay, we're all crazy. But it's funny because when I got out of school in '87, our restorative professor made us sign an ethical contract that we will not do these posterior composites. I mean, that's how old school I am. I mean, 87. And I just want to say that to the kids who are out there wondering what my view is on a mercury is that when mercury in a silver filling, when it's half mercury and it bonds to silver, zinc, copper, and tin, it's an insoluble salt. And if you triturate amalgam and swallowed it, 24 hours later, you'd poop it right out into the pan. But it's the mercury in the ocean that due to burning coal, mercury in the ocean has gone from 1 part per million for the entire ocean in like 1950 to now 4 parts per million. But that's free ethyl methyl mercury, sinks to the bottom, is gobbled up by any bottom feeders like shrimp and lobster and clams and oysters. And then if it's a big fish that drinks a lot of water, like a big tuna or something like that, that's ethyl methyl mercury that's absorbable. So it's so funny because I see these batshit crazy dentists that are anti-amalgam and extremists, and then they're sitting there and they're like, you know, real healthy and they don't eat red meat and they're sitting there and eating all this seafood. And I talked to a doctor who studies premature lost babies, whether that be, you know, an accident or abortion or whatever. And there's a lot of mercury toxicity in the brain at even a child 3 months, you know, conceived, but it's all ethyl mercury, methyl mercury, and it's all traced back to dietary seafood, not the mother's, not an amalgam. An amalgam in the mouth is an insoluble salt, and it has some antibacterial properties where composites don't, glass ionomers do. But my gosh, to me, I think one of the, I think on a guy like me, like you're talking to me, you don't know that I have 7 gold inlays and onlays and crowns. I'd rather have gold, metal, I mean, take a metal nail and then take a plastic nail and tell me which one you want to put in your molar for 40 years. I call it the aesthetic health comment. Now, obviously, if you're a woman and you put on mascara and eyeliner and do your hair and nails and mani-pedi and you're totally into cosmetics, I get it. And we'll do all the tooth-colored stuff. But, God, when a short, fat, bald guy like me walks in, wouldn't you rather just throw an amalgam in a buildup that's going to last twice as long as a composite? I mean, if you're doing something for me on the aesthetic health compromise, the only thing you could do is maybe put a bag over your head so you couldn't see me. And I just want it to last. So I'm going to pin you down on another specific. I'm going to get you on specifics. Molar buildup, post or no post? What are you thinking when you're thinking about a post? What should a young kid walking out of dental school think about? They just did a molar endo on a molar. What should their brain be thinking when they're analyzing a post?
Well, number one, you've got your failure. If you have a failure, is going to be from a lack of failure. Just if you don't have enough tooth there, it's going to fail. I use post, but I make sure my posts are essentially the same size as my endo prep, my canal. I don't like to enlarge it greatly with, and you can get all size of fiber post, and all they're good for is to retain the core. You're gonna make a prettier, you send a prettier prep to the lab. They will not keep a crown from failing. They're, in my opinion, they will not. Do I use them? I use a lot of them because I like to have them, my build-up to be nice, shaped well, and when I send it to the lab, I want them to have an easier job. I don't want to have an old chunky-looking something for them to work with. And people send those things to labs. I've been to labs and seen them, and it's a little bit embarrassing to me, but that's the way they do it. Now, to be honest, it's harder to put a post in if you've got amalgam, if you use amalgam, unless you use a metal post. And I'm not real fond of metal post. If I could get away from metal post, I would. I'm not real fond of, a lot of people say cast posts are great. And in my 50 years, I've seen more split roots from cast post than I have from any other type post. And I think that's because it's extremely difficult to get an exact copy of the canal that it will fit. And after your cement breaks down, it starts moving and you see split roots. But that's just that's an opinion. I don't have any science to show that, but I don't use cast post anymore. Metal post, ironically, the only metal post I use are the flexi flange. Barry's post, the EDS post, because I think it creates less stress in the tooth than others. I used one the other day, and people say I never use a post, but a lady came in with a front tooth that was sheared off. She had fallen off the back of her tricycle riding with a grandchild, which she shouldn't have been doing, and broke her crown and her tooth and everything off. So what are you going to do? Well, I'll build you up something well, what I did was I took a flexi-flange and I ground the threads off except at the top, which is where it bonds, or where it really holds, and the rest of it's cement. And I put that in, and in her case, since the tooth was already non-vital, I had to do a root canal the same day. So, you come in, you got to do a root canal on somebody on Saturday morning by yourself, and all the trays are set up. But I put her back together with a post, and that was the only way I could repair her was with a metal post. A resin post or a fiber post would not have worked. I put one pin in as an anti-rotational device, and that thing it's solid as a rock.
So you were all alone when you go in there? Jeanette doesn't go in there and assist you?
No, not anymore. She used to, but not anymore. I know most of these people, and we don't. She used to, if it was somebody I didn't know, she would go. But now a lot of my calls come from the ER. I'm on staff at the ER, and the governor of Georgia just made a statement that all ERs will be covered by dental. They will have dental coverage. So a lot of people are going to have to start getting on hospital staffs because the governor has made that statement.
Well, it's sad because, I've been out here in Phoenix since 1987, and I mean, they go to the emergency room and anything with a toothache, I mean, they can't do anything. I've had people walk into my office with a 2-foot by 2-foot sagittal x-ray of their head. Yeah. Trying to find and it's like, are you kidding me? How? So they don't have any intraoral photography. They don't have they have no way to diagnose. So they give everybody the same thing, amoxicillin and Percocet, which is probably not a good public health policy.
Yeah.
Yeah. But I want to get more specific on you. So when we got out of school, x-rays were only 2-dimensional. And now we have 3-dimensional x-rays with these CBCTs.
Yeah.
So you practiced probably 25 years without ever having access to a 3-dimensional x-ray on a molar. What do you think about CBCTs? Can you be a good endodontist? Can you do good endo with a 2-dimensional x-ray? Or would you say a 3-dimensional x-ray is standard of care? Or talk about that.
Well, at this point in time, I don't think CBCT is going to be standard of care because so few people can afford them that are doing, 80% of the root canals in this country are done by general practitioners. And Ruddle, when I was there, and both of them said, a lot of endodontists don't think we should be teaching general practitioners. And he said, who's going to teach them to do better endo if we don't do it? And I respect both of those guys tremendously. And that's the reason I went, was because I wanted to meet them before I quit. It was, and like Martin.
Who, Martin Trope and Cliff Ruddle?
Yeah.
Legends.
And I walked in, Trope was a small group. It was like 13 people. And he walked in, he looked at me, he said, what the hell are you doing here? He said, you've been doing endo for so long, I don't know. I said, well, I wanted to meet you, Martin, and I wanted to listen to what you had to say, and I was sure I'd pick up something. Well, I came back. I'm now using bio-erase files because of listening to Martin, and I think his thoughts are excellent. And we have not been preparing the apex for the root. And at one point in time, I was doing that and using an O2 taper to go down an 04 or 06 and make the apex larger. And I got caught a lot of flack on Dentaltown for over preparing my apexes. And now Martin's come along, and we've got bio-raised files that have that. And so
I think the next question should be basically is do you think is the number one cause of a failed root canal? And is it really cleaning, shaping, obturation, or is it really missed anatomy? I mean, there's a lot of people who think the number one reason of the most common reason of a failed root canal is a missed canal. Do you agree with that, or go through why you think root canals fail?
that is a cause. And I retreat a lot of endo because you were mentioning people that I have three dentists here in town that refer cases to me rather than do the molar endo. There are some people that are not able to leave town. The nearest endodontist is 70 miles from here. And so a lot of people would rather just come to me and let me do the endo. And the three dentists trust me to do a good job of the endo. So, I missed the question. Go back to it because I got off.
Well, when I'm focusing this on someone who just got out of school, and when you're sitting there doing a root canal, there's so much talk about, cleaning, shaping, obturating, EDTA, all this stuff. But would you say it's fair to say the number one cause of a failed root canal is missed canal? Would you agree with that statement, or would you disagree?
I would say let's call it missed anatomy. Because a lot of times I retreated one that was done by my partner, and he's a solid practitioner, but he had created anatomy that he didn't feel. He had a strip perf on the apex, and so when he filled it, the apex was wide open for about 3 or 4 millimeters up the canal because he had transported it. He went down with an F3 pro-taper, and the canal wouldn't take that. So he created anatomy that he didn't feel. MB2s, the numbers going down. Martin said that we find his residents find 52% of the MB2s, which was a smaller number than I thought because, when I got out of dental school, Howard, my endo book did not even have upper first molars having MB2s. That wasn't in there. And then later on, it was 25% of upper first have. And then it was, and you wonder why somebody didn't just take 100 of them and slice the roots and say, well, I'll be done. They all got an MB2, except a few. I think 90% of the upper first molars have MB2s.
But do you consider, but if the MB2 joins the MB1 in like the first third of the root, it's probably less of a problem than obviously if the MB2 goes all the way to the apex.
Yes, I mean, if it joins and you miss it, then I don't think you missed anything because you're going to fill it. I think that it would be nice to clean that canal out and disinfect it and do everything we do to it, but it's going to be sealed up pretty well if you do a good job of endo. If you do a good job of obturating the MB.
And that is the huge advantage of a CBCT. I mean, what I'm reading from guys like you and on Dentaltown is that, the most common failed root canal is a maxillary first molar because it's a missed MB2. Second would be a second mandibular molar because the distal canal has 2 canals, sometimes one, not one, sometimes 2. Even mandibular incisors often have a lingual secondary canal that's often missed. But I want to go back to one comment before you missed about some of these instructors that don't think general dentists should be members of or learn endodontics from endodontists that you were saying that Clifford was talking about. And I just want to say, and there's some out there that I don't want to throw on a bus, but I think they're arrogant and I think they're bad people because there's 19,022 small towns in rural America. And those people are paying taxes to pay for these public dental schools, and the specialists who try to keep specialty stuff out of the curriculum and to general dentists, they might have an argument for the 117 largest towns in America where half of America lives, and the 9 specialists are all there. But when you get back into rural America, I mean, I'm from Kansas. I mean, it's just town after town after town. There's no specialists. In fact, I would venture to say that 20% of all the towns in the United States don't have a single specialist. So when you go to that dental school, or some of these elite endodontists will have programs where general dentists can't apply. I mean, that's just arrogant. And then they'll tell you that they graduated with $300,000 student loans. Dude, your tuition didn't even pay for half of the cost of that dental school. And it was the rural America paying taxes to fund your little state education. And then those arrogant idiots don't want to teach general dentists, and then those people go back. And when you're in a town of 1,000 or 2,000 or 2,500, and there's 0 specialists, the bottom line is, there's another specialist that no one ever talks about. They always talk about endodontists and periodontists and pediatric dentists and oral surgeons and now oral and maxillofacial. They never talk about the public health dentist. And I think deep down inside, we're all a specialist, because at the end of the day, we're all a public health dentist. I mean, when I opened up my dental office, I spent a day a week for 2 years. I spent every Friday for 2 years, no revenue, just trying to get Phoenix to fluoridate their water, because I knew in a town of this big, I mean, this town's a monster. It's the 5th largest town in America. I knew getting fluoride in the water would be 10 times more important than me sitting on an assembly line, drill, filling, and billing. We all have patients that walk in that need emergency care that we know we're never going to get paid and all that stuff. So I think we're all specialists. We're all public health dentists. There's 7 billion people on the planet. Everybody's got different needs. But I want to pin you down to some more specifics. Apex locator, do you use them? Which one do you use? Tell us your thoughts on Apex locators.
I think they're an integral part of doing endo. I don't think you can do endo competently. Now, I might be going out on a limb here, but I don't think you can do it competently without an apex locator, because the radiographic apex is going to be wrong about 50% of the time. So and you have to use that apex locator during the filing, because you're changing the length as you go down. So I check mine 3 or 4 times to make sure that well, number one, that you're not straightening the canal out too much. If it starts getting too short, then you straighten it out too much. I think they're integral to doing good endodontics.
Are they all the same? Do you like one more than the other? Any thoughts on brands?
I use 2. I hate to say this, but I've got 6 apex locators. I use, because that's how important I think they are. I use the J. Morita primarily.
Which is Root ZX, J. Morita from Japan.
I use that one primarily. Parkel's apex locator is excellent. That locator is excellent. So I have 2 Parkels in case my Morita goes down. I got 2 Parkels, and they're very accurate. I actually have one from China that's excellent. So it's
what's the name of the one from China?
I don't remember. I bought it on eBay. I hate to say that, but I bought it on eBay just to have another one.
Why do you hate to say that? Why does that?
Well,
bother you?
It was sold on a dental site on eBay. You can buy. I actually have a motor that I bought that I haven't used yet, because the one I got's working fine. But I've got that backup. If it stops, I've got another motor. The apex locator is just like the CBCT. I think eventually that will be the standard of care, but that won't be in my lifetime, my practice life.
Well, in a way, the CBCT, I don't like the name CBCT, because when you talk to the maxillofacial oral radiologist, they say that the name is wrong anyway, because the dental ones aren't even the CBCT under the strict definition. Yeah. I just like to think of it as we've gone from 2-dimensional to 3-dimensional, and a Root ZX is 3-dimensional. I mean, because the radio is 2-dimensional, so an apex locator is really the entry-level 3-dimensional.
Absolutely. And if I have a case that I'm concerned about. We have an endodontic group here that have a cone beam, and they will do one free for me and put it on a CD, and the patient will bring the CD to me, and we plug it in, and we can look at it and see if I missed an MB2 or what. I found one upper molar one time that had 6 canals, and every one of them had a separate portal of exit. I mean, it was not just merging. There were 6 canals, actually 2 palatal canals. I'd never seen that before. Wow. But the anatomy is so complex on a lot of them that, and if I get concerned about it, I send them to the orthodontist and get me a 3-dimensional view, a real 3-dimensional view.
And that's another thing I tell kids. You know, there's book smart dentists, and there's people who got through dental school. You got to be book smart to get through dental school. I mean, anybody who gets A's in calculus, physics, chemistry, but you're book smart. You know, if you got a dental degree, a med school, a law degree, you're book smart. But it's the street smart ones that are crushing it. And I've never met a specialist with a CBCT where if somebody in their neighborhood sent a patient over for one, they'd be glad to. Are you kidding me? They want your referrals. They'd like to meet you. You're coming to them instead of them begging you to go to lunch or something. I think it's the best continuing education. I mean, there's dentists in this valley like Brad Gettleman, one of the greatest endodontists I've ever met, who he has an open door policy. Any kid that walks in there and wants to watch him do root canals all day, and he just thinks it's fun. He just enjoys having a buddy for the day. I want to go back to on the Root ZX. Talk about, are you doing hand file? I mean, most people think of a Root ZX, an apex locator, that you're putting in a hand file and you're measuring there. Where do you leave hand files and go to rotary files? And do you put the apex locator on the rotary file? I mean, some people leave the apex locator on, so when they're doing 300 RPM NiTi, they have the apex locator on the whole time. So start with the first question is, where do you branch from hand files to rotary files?
Okay, I'm gonna generally I never go higher than a 15 hand file.
What do you start with? A 6 or an 8? Or
6.
6.
Yeah, and usually I like for my patency to be a 10. Because of the technique I use to obturate, if I get it too big, I'm going to get a massive pull. If it doesn't hurt anything, it just looks ugly. But I like to keep it at a 10, sometimes a 15. Of course, you get some that already have a huge portal of exit, and it doesn't matter what size file you use there. But I don't see, when you get past a 15, now with the Martin's technique with the BioRace files was you take it to a 20 hand file.
Which file was he talking about, Martin? Bio what?
The BioRace. They have several. He's got another one.
BioRace?
Yeah.
Now, is that his file? Or who makes that file?
I think Brasler makes it.
Brasler, okay. Brasler's out of Georgia. That's your neck of the woods. Aren't they in Savannah, Georgia?
Savannah, yeah.
And where's Martin out of?
Martin practices in Philadelphia.
Philadelphia, okay.
Martin does a lot of development. I think, he was integral in the development of Reslon, which is now gone. It was, I think it was an excellent material.
That was Ultradent took that, did that, didn't they? Ultradent?
No, that was Sebron that had Reslon. Ultradent has EndoRes.
Okay, EndoRes.
And Endo, it's still available, and it's both of them have the same weakness in that they can't stand to have any oxygen when the sealer is curing. And if you leave peroxide or any bleach in there, then the sealer's not going to set. And I think what happened, it was just too technique sensitive for the average dentist. Like I said, we're lazy. We don't want to go to the trouble of cleaning out the canal. And so when they took it off the market, we obviously had to go to a different sealer. I'm using now. I'm using the epoxy. The epoxy. I can't remember something plus.
AH26.
Yeah, plus. Yeah,
That's
but
what I use.
yeah, it's an excellent sealer, and but I still go through the same process of removing the bleach. I don't like to leave any bleach in the canal, but back then a lot of the people just Dr. Dan Fisher, um, he came on Dentaltown and said that we could not use RC prep with EndoRes. And I said, I posted that, well, yes, you can, because I do, and I have great success with it. And he called me on the phone and he said, Guy, you got to go back on there and tell them not to use it, because all of them aren't doing what you're doing. A lot of them are leaving the RC prep in the canal. You're cleaning it out. That's the reason it's working. And so you got to go back on there and tell them not to use RC prep. Use Vaseline or something, but don't use RC prep. So now we use his.
Okay, Guy, I got to stop you right there. There's a lot of people who don't know what RC prep is. Will you explain what RC prep is?
RC prep is a lubricant for files. It has EDTA in it, and it obviously has some peroxide in it.
Explain what EDTA is for him too.
That is a form of acid that removes the smear layer from the root, inside the root, so you can get some penetration of your bleach and your any of your irrigants that you put in there. You need to remove the smear layer so you can get some penetration.
So do you always use RC prep on all your endo?
Not anymore. I use EDTA, but I use Ultradent's. I'm thinking it's Filease is what it's called, I believe.
And it's just a straight EDTA.
Yeah, and it's a lubricant.
And
it's a gel form.
For our viewers, he mentioned a conversation with Dan. That's Dan Fisher, the founder of Ultradent. They're in South Jordan, Utah, outside of Salt Lake. He's one of the sweetest, nicest, hardest working guys in all of dentistry. The guy does it like 18 hours a day, 7 days a week. And he's got to be, how old is he? He's got to be over 60. I'm 52. He's got to be.
He's over 60 because I went to, and he's kept going. I went to an Ultradent Elite meeting out there, and when I got there, it was almost like a funeral, and nobody was talking, and it turned out Dan had lost his son shortly before, and I don't know exactly what the circumstances were. It didn't really matter. He'd lost his son, and so we did not expect to see Dan. But at the end, the closing, and I had just lost a grandson shortly before that.
Oh, I'm sorry.
And Dan shows up for the final closing lecture and does a magnificent job of pumping us up and showing his class. He's a classy guy, and it's. I went to a meeting in Atlanta, and he saw me and came up and spoke and invited me to go out to dinner with him. And I thought that was very unusual. We went out to dinner, but we were talking about endodontists not wanting to teach general practitioners. Ben Johnson was introducing the Vortex Blue at that same time. And he was giving a course in Atlanta, and I was already there. So I called him and asked him if I could take the course the next day. And the lady told me that it was only for endodontists. They didn't allow general practitioners to take it. So I called Tulsa and told them that I thought they were missing about 80% of the market out there, and it was pretty stupid to say something like that. Well, I got a call from Ben, and he apologized, and he said that next course we had, I could come free. He would be glad.
I got to tell you my Ben Johnson story. First of all, I hope I don't get this wrong. I don't want to throw Ben under a bus, but I don't think he actually went to endo school either. I think he just limited himself to endo back in the day.
I think you're right.
Yeah,
But
so I don't think he's got to be the greatest, most famous endodontist in the world. He's from
yeah,
Tulsa, Oklahoma, and that's where Tulsa Dental was started, which was later sold to Dentsply. So all that Tulsa Dental product stuff you see was started in Tulsa, Oklahoma, with Ben Johnson. I got to tell you how street smart I am. I'm most proud of this story. So Tulsa Dental was coming out with all this stuff, and I'm in Phoenix, Arizona. I'm confused. And I call him up and everything, and I said, I want to talk to the dentist, Ben Johnson, the endodontist or whatever. And so he got on the phone and all this, and I just had all his questions. And he said, I said to him, I said, you know what I really wish? I said, Phoenix to Tulsa on Southwest Airlines, only like $200. This is back in like '87. I said, I wish I could just fly down there and spend the day with you. He said, do it. I said, really, when? He goes, I don't care. He goes, I'm in my office seeing patients Monday through Friday, 8 to 5. So I hopped on an airplane and went down there and spent the whole day with them. And this is a priceless course. I mean, people will go out and spend $3,000 for some weekend course and some hooty fluty root canal deal or whatever. And they've got rockin' hot endodontists in their same zip code that if you just call them up and say, buddy, can I come watch you? I mean, I bought a round trip plane ticket on Southwest Airlines and got to spend the entire day with Ben Johnson. I mean, how cool is that?
That's the way Ben is. Ben did not have a clue that I was turned away, and that was what he said. I did not know that. If I had known that, I would have invited you personally to come. But the way I got started, we go back to the endodontist teaching, was my endodontist was in St. Simon's Island, which is south of Savannah, and he was just getting killed. There were so many people referring to him. He just couldn't do it all. And he had seen the stuff that some of us were doing on bicuspids and, anterior teeth. And he called us, three of us, and wanted to take us out to dinner. And we all met in an in-between place, Waycross, Georgia, and we went out to eat dinner. And he says, okay, you guys got to help me. You got to do your own molars. He said, I can't do it. Y'all are referring more of these to me than anybody else, and all of y'all are capable of doing your molars. He said, I'm going to come to Douglas. We all meet there, and we'll have 3 days, 3 weekends where I'll come over, and we will just talk endodontics, and I will show you slides and stuff. So that's how I got started in it. And then after that, he recommended I take the course at the University of Florida, which was 3 long weekends, and Dr. Vertucci taught that. And that's how I got started in Rotary. It was the only thing available was profiles back then. That was the first one that came out, and it was more or less a crown down technique. But that's how I got started. Was an endodontist told me, listen, you got to help me. And at one time there were a lot of endodontists on Dentaltown and on Roots. Roots was not very good for general practitioners because Sirota was pretty rough on us. But Dentaltown was great. Endophiles was great. We had people like John Levin was on there. I don't know. He's in Lafayette, Louisiana. He's one of the best endodontists I've ever seen. Bill Watson was on another group. Bill Watson was probably maybe the best endodontist that I've ever seen. And that includes all of them. But you don't hear much from Bill. But
what was Bill's last name?
Watson.
Okay. Where was he?
He is out. I'm trying to think. He sort of disappeared because he had like 8 children and he was having to work pretty hard. But he was, and he might have been, I'm not sure. But
That was a good point. When all these students are worried about all their student loan indebtedness, well, they can balance that off with a nice, clean vasectomy. Then that,
yeah, that's right.
of course, don't take advice from me. I had four boys before I had my vasectomy.
Yeah,
I want to pin you down on a couple more things though. But when you said 15 was the largest hand file you go, then you switch to rotary.
yeah.
Do you leave the apex later on the rotary file, or do you just periodically pull out the rotary, stick in a hand file, and check with the apex locator?
I try. I try. I don't leave it on. It irritates me on the file. So I take it off the file and
Off the
about
rotary file.
off the rotary file. And after about a couple of files, I'll go back to it. But now,
And when you do and when you're doing rotary, are you doing crown down, bottom up, combination?
no, I'm doing whichever the. I've got my own. I've got my own technique, and I use several files. I use ProTaper Next. I use BioRace. I still use some ProTapers with M-Wire. Um, I have profiles still from way back that if I want to enlarge an apex, I have O2s. I use K3s to finish my shaping of the canal because K3s are about the only file out there that you can buy now that's landed. It has lands on it. So you will get a true taper when you go down the canal. It will not be a variable taper that you pick up with non-landed files. They have most of those are variable taper. So if you just use that file, a lot of times the cone will not go down. And the technique I do for obturation, I need a master cone to fit well. I use something called System A that was taught to me by an endodontist, Jerry Avalon, who Jerry went into a state of depression, and we sort of lost him for a while, and he showed back up, but he was a great endodontist, went to the University of Virginia, but he taught this System A, and we used a PacMac. You can just use one cone if you have a cone that fits well, you just put the one cone in. If it doesn't fit as well as you want it to, you can just wedge a couple of cones beside it. I don't do lateral condensation. I just wedge it in there. Go down with a PacMac to about 5 or 6 millimeters from the apex. It tends to push the PacMac out. Then I condense it with pluggers. So I'm using a warm vertical when I do it. But I'm using a PacMac. I don't have an Optera. Well, actually, I do have an Optera. I just don't use it. I've got a lot of endodontic stuff that I don't use anymore. But
My advice to the file companies is it would sure be nice if every single person that made a file would make a gutta percha master cone with the
fit it.
same they go to these they go to these extremes to make a Cadillac, Ferrari, Lamborghini file, and then their gutta percha is like some used car, from
Right.
from another planet. It's like I wish they'd put the same effort into the exact specifications. So if every master apical cone was exactly the same shape and size and length, that would be so much easier. And God, I almost would rather pick a file system that matched up my gutta percha obturating system than vice versa. And I also want to highlight something just in case some of these younger kids missed it. You said something very profound that a lot of people miss, and that is they're talking about bonding strengths on the buildups and files and all that, but you mentioned the ferrule. And 28 years of watching these, if you don't have 3 millimeters of natural, real tooth stripe, they call it the ferrule. And if you don't have 3 millimeters all the way around the tooth, your crown's not going to stay on. I don't care what your buildup is. I don't care what your bonding agent is. You need 3 millimeters of real stuff. And if you don't have it, you got to go down, crown lengthening, whatever. Or in these modern days, just pull the tooth out and go file. I cannot believe the hour has gone by, and we have it has been an hour. But Guy, I just want to thank you for 50 years of doing dentistry. a decade of, I mean, I've read, you got 6,000 posts on Dentaltown. I probably read 10,000 of your posts back in the early days of Root ZX when we only had emails. And you're a legend in dentistry. You've done so much. I can't tell you how many times I've been at a dinner with a conversation where we're talking endo, and people just say, well, Guy said this, Guy said that, Guy Moore said this. And I just want to thank you for all that you've done for dentistry, all that you've done for endodontics, and thank you so much for sharing an hour with me.
Thank you, Howard. I really appreciate it. I enjoyed it. I enjoyed meeting you. You've done a magnificent job for dentistry also. If you look at what you have done with Dentaltown, well, actually, it is the site now. Where else would you go if you wanted to learn?
Dentaltown's only valuable because guys like you share so selflessly. I mean, my God, and to my viewers out there, I don't think there's a question you can't ask Guy. I mean, about just post it, and he's always there answering them day in and day out. And for that, I thank you so much.
Thank you.
All right, have a great day.
You too.
All right, bye-bye.
Bye-bye.